Welcome to the Africa Public Health Podcast from Africa CDC, your go-to source for information on key continental health security issues. I am your host, Andisiwe Michelle May. In this series, you will get valuable insights from African scientists and researchers as we unpack important public health topics that impact the continent and the latest developments in public health research. In this episode, we are joined by an esteemed public health expert and infectious disease epidemiologist from Liberia, here to discuss the importance of improving health research and development at the Africa CDC.
My name is Mosoka P. Fallah. I had always had an ambition to become a doctor from a child. So I graduated from high school and went to the university to do chemistry and biology. And then the Civil War started. It took me 10 years to obtain my first degree. In my country, we do a first degree before medical school. And then in between the war, then I went to med school, 2.5 years in med school, in between the war. Then I had a scholarship to go to the US. I was thinking if I was going to achieve my dream in the midst of the war. I got to the US, still pursuing medicine. I did a first master's in my research on malaria resistance in Africa. Then went to do a PhD in immunology and microbiology with emphasis on vaccine development for streptococcus pneumonia. But I always had in mind to come back to Africa.
Dr. Mosoka serves as the acting director for the Directorate of Science and Innovation at Africa CDC and has had a remarkable career journey, from his early ambitions in Liberia to leading pivotal research initiatives across the continent.
Then after my PhD, I went on to Harvard to study. So I came back to Liberia after my graduation to run a USAID project to help develop the popular health workforce. Somewhere in the middle of as I was concluding the training, Ebola struck. Then the Ministry of Health called me and said, you have to help. So I ended up staying in the country to organize most of the massive surveillance, community surveillance, trying to control the outbreak. So the outbreak ended. I was on my way back to the US when the president asked me and said, "Hi, can you kindly stay and help to set up the first ever National Public Health Institute?" So my colleague and I were tasked to set up the institute. So we set up the institute, and I said, "Well, I'm done." And then they said, "No, you can't go." The president then asked me to be the chief scientist for the institute and the deputy director. So long story short, I stayed and became director. So went through COVID, eventually moved to the World Bank as a consultant to help do pandemic diagnostics for a few countries, Ghana, Sierra Leone, Liberia, Cape Verde, and the Gambia. In between that, I got a call to come over to Africa CDC to support the continental COVID-19 initiative that was started between Africa CDC and the MasterCard Foundation. So that's my life story in maybe 2 minutes.
Thank you so much for sharing a part of your incredible journey with us. And on that note, I think we can dive into today's discussion. To start us off, what is the current state of health research and development in Africa?
Where we should stand in terms of the continent when it comes to research, we are a continent that is lagging. On a query of multiple sites, whether it was the USG.gov or WHO clinical research site, it has clearly been stated that of all the research globally, Africa accounts for 1.5 to 2%. That's around, depending on the number you go, some people say 7 million. There's only 1.5 to 2%. And of those research, it's around 5 to 7,000 in the last 10 years. That's how many score the research we do on this continent. And further studies have shown that of all the research initiated on the continent, only 3% go to completion. I'm bringing this statistic to go towards the key question of policy. And of the 5 to 7,000 research in the last decade on the continent, 60 to 80% of them are contained only in Egypt and South Africa. So the rest of the continent is still specially do research. And one of the key reasons is that we don't have a continental coordinating mechanism. They also spoke like the capacity for ethical review and regulation of trial on the continent. there is a measure, what they call time to initiation, when we start a trial on the continent. There's a debt for human resources. So essentially, we've come in an environment that has a challenge, but that has provided opportunity. Africa CDC has been leading and recognizing this gap, which is reflected in our strategic plan to support local manufacturing. The way we can do that is to be able to invest in the R&D, research and development space. And so Africa CDC work with other partners to develop the clinical research ecosystem roadmap. It's a 10-year roadmap for the continent, so we are moving towards that. And I'm happy to say that many of the donors have caught onto that vision, saying that Africa CDC is strategically placed to lead that continental policy. So in essence, there's a lack of continental policy.
Are there any other policies or ethical frameworks that exist that are shaping the landscape and working towards addressing some of the gaps that you mentioned?
There is the Algiers Declaration that asks for 2% of countries' budget to go towards R&D, but that has not been revealed. I think only 2 to 5 countries are able to do that. So there's a gap, and that's one of the things we have come to fill in. I mean, it started even before I took over the position to develop a continental policy, a continental scientific coordinating committee, a continental ethics committee on the framework of the clinical trial ecosystem for Africa. That's what we are working on. As a matter of fact, the Gates Foundation, CEPI, and other partners, the EDCP, have given us funding to actualize that. We are developing the framework and the policy. We're not moving the draft to a strategic plan. We're also moving towards developing the mapping of clinical trial site and capabilities. So essentially, in response to your question, there is no fine policy coordination framework. And so many persons have reported, and Africa CDC has the vision to fill that gap, and there are concerted effort to be able to develop a continental scientific research, scientific coordinating platform together with policy.
Thank you for that great overview and the insights you've shared, which lay the foundation for today's topic. You mentioned some major gaps that you've identified so far. What impact have these challenges had on research and development on the continent?
Some of the consequences are many. There is one on health security. Africa depends on external producers to manufacture 99% of our vaccines. Africa depends almost 80% of medical products. We have no control on the regulatory guidance on those external products. I'm actually writing an article for the DG to show that there's a case last year in the Gambia when over 67 children died from a couple of cough syrup that was imported into the country, but there were no strong regulatory activity, there was no strong pharmacovigilance system on the continent. And because we depend on external manufacturer, the investigation that was conducted by WHO found out that there were high level of contaminant in those cough syrup. We now have access to the data. We now have a way to, because basically it's out of our control.
The Indian government has started an investigation into 4 cough syrups manufactured by a Haryana-based pharmaceutical firm after the World Health Organization's warning that they could be linked to the deaths of 66 children in the Gambia. The cough syrups have been manufactured by Messrs. Maiden Pharmaceuticals Limited in Haryana's Sonipat. The UN Health Agency cautioned that the contaminated drugs may have been distributed outside Gambia also, with possible global exposure.
Finally, WHO has today issued a medical product alert for 4 contaminated medicines identified in the Gambia that have been potentially linked with acute kidney injuries and 66 deaths among children. The loss of these young lives is beyond heartbreaking for their families.
The sad thing was that of the cough syrup, it was not allowed to be used in India. So essentially it was exported to Africa. That's one instance. So we depend on country, even when there is outbreak and there are issues, like in the case of COVID, when there was no flight, we depend on external manufacturer. And a recent study showed that over 36% of the manufacturing companies that we depend on from India had to be closed down because they did not meet the minimum standards. So essentially the consequence is that we are receiving products, medical products, vaccines, that we have no control over, that we do not manufacture, that we do not influence the regulatory standards. From the point of view of health security, imagine all of our vaccines being produced externally. Also, the fact that whenever we do clinical trial for new products and drugs, we take a subset of the population, and we know genetics now more and more is becoming more and more evident that genetics play a role. And so, but most of the clinical trial, imagine clinical trial for cardiovascular diseases, cancer, other diseases, the sample population, the study population are often the north, and in when I say the global north, and our genetic population we know, composition we know on the continent is diverse. We are not tested with those drugs. We are only given the finished product. And we do know even when you produce drugs, you need to follow them up. So essentially drugs are produced on a different population and we become the end user of those drugs. So that's a major issue we have, that one, we depend on others to supply of the drugs. So it's fragile, it's costly. Two, there are no minimum standards for us to have control of what happens. That's why Africa CDC and African Union is working towards the National Regulatory Authority through AMA. So essentially, we are vulnerable at all levels. We get affected by drugs. I said to you, the total research that we are doing on the continent is only 1.5 to 2% out of 7 million. Can you imagine? There are resources that are varied across the continent, but because we are now having a unifying platform to bring the continent together so that we can be able to harness and leverage upon each other's strength, it's undermining our ability to conduct larger research. And so those are those gaps that we're trying to be able to fill through developing a continental coordinating mechanism and framework, but essentially we remain vulnerable. Our vision for local manufacturing cannot be fulfilled if we don't have the pipeline of the R&D. So essentially we now have a big goal by 2040 to manufacture 60% of vaccines and other products. But don't forget the vaccine and the medical product is the final upstream of the whole pipeline. You need to have strong R&D, and for now our R&D is fragile, weak, inadequate to supply that vision. So there's a need, an urgency, there's a speed to move quickly to develop a solid framework. I'm happy to say that the European Union, Team Union are giving us a consultant. CEPI has given us a consultant, and over the last few days we've been working on developing a continental tool to really be able to grasp this extent of the clinical research on the continent, and then also ready to finalize a strategic plan. But indeed, there are critical issues and we remain vulnerable as a continent.
Can you tell us more about the continental tool and what it is?
Excellent. So basically, we want to go from end to end. We want to go to every country, 55 member states, using our resources, because Africa CDC has in-country teams, has teams at the 5 regional centers. So what we're trying to do is to adapt it to REDCap. So basically go and look at in every country what is the clinical trial ecosystem. We're going to start from the basic science, the preclinical, the clinical level, and see what exists in each country, how is the human capacity, how is the regulatory and ethical framework. We're going to go and then basically at the back end here, we are setting up a system. Actually, we're in the process of recruiting a senior technical officer for technical solutions. So we're going to build a huge repository within the division of knowledge management, and we'll bring all that information from every country to know the actual reality of research on the continent. And there will be 2 main goals. After we have gotten the data, it's going to serve as a stop and shop, one stop and shop place that anyone wanting to do research can go. You can connect researchers, but the second thing will be then to look within the data we pull to see potential centers of excellence that can be used to strengthen the capacity of the other research, but to have a generic map out and understand in actual sense in every country how many research centers and institutes exist, what sort of research is going on, who is funding them, what are the stakeholders, look at it and say, okay, this is a continent, then that would then guide the strategic plan, the policy framework, and make available a large repository that one can access. A casual observation looked at some of the mapping that is done on the continent, sits in Europe, sits in America, sits in different institutions, but there's no single centralized place to have a global picture for on research ecosystem for the continent. So that's it. So at least the tool of done, we're trying to now deploy the tool of our team on the ground to be able to get detailed information, situation analysis of the research in every country. And that will help us a lot to know the resources and the challenges we have and how we can build a stronger team for research to be ready to increase the research on the continent.
During and in the aftermath of the COVID-19 pandemic, were there any potential areas for policy reform or capacity building efforts that were identified to ensure ethical conduct and oversight of research activities and to further bolster research and development going forward?
So there was a big continental study with support from US CDC, partnership with US CDC, Africa CDC, European Union, European CDC, in the midst of the outbreak, where Africa CDC led a continental sero survey to really determine the extent of the infection on the continent. Those meetings were held with stakeholders to design and test the serology of COVID-19. Africa CDC led on that, and it was multi-partner initiative, and that gave some information as to the way that the disease was spreading, and even the ones the one that were not obvious, and the one that did not report. So it helped us to give a general idea of sort of the epidemiology of COVID-19 on the continent. And then also there was a partnership with the London School of Hygiene to look at the risk communication, the perception, the barrier to COVID-19. What were some of the social science factors that were influencing acceptance or denial or rejection of COVID-19? So that was the second research that was done. Also, under the SLL initiative, Africa CDC was very intentional. One of the things they did was to invest in implementation science across 12 countries on the continent, which is one of the most diverse study, to look at a couple of questions such as enhancers and barriers to uptake of COVID-19 among healthcare workers. It looked at the impact of COVID-19 on health system. It looked at the impact of COVID-19 on even routine healthcare system. So that research was done across 12 countries. There have been multiple publications, and there is a supplement that is coming very soon, the Journal of Public Health in Africa, that look at different aspects across multiple countries, West Africa, Nigeria, Eastern, Northern. So it was a very diverse continental study. So that was one good effort to show that Africa CDC could partner, and it was done with Infectious Disease Institute at Makerere University. So it's good thing that it was a soft collaboration, Africa CDC partnering with an institution on the continent to launch this big study, and in turn, IDR Makerere partner with universities across different countries and the National Public Health Institute. So this is sort of the beginning framework that was shown that indeed Africa CDC could lead continental research, partnering with the Global South institutions, and because Africa CDC has a unique advantage of convening power to enter countries, they can partner with ministries of health and member states. So that study was done, and we were trying to publish multiple papers. It was called the Proof Study. And so it clearly showed a country like Ethiopia, all of them, there was someone who were looking at different things, looking at the impact of the intervention on the health system, the data health system. The DHIS2 was done. And so it clearly was done. It was shown that in the midst of an outbreak, one can partner and lead to continental research that can then give answers, as to how is the outbreak unfolding and how can we find answers quickly by means of research and looking across different contexts, different countries. That was a good study. For example, Southern Africa, Zambia, Rwanda, they were all part of this huge multi-country implementation science research to look at those variables. And the last one is that we use this opportunity of the COVID-19 or the challenge of the COVID-19 to be able to invest heavily in genomic sequencing. As you may know, when COVID started, there were only 2 countries, in South Africa and Senegal, capable of doing genomic sequencing. Now that has increased to 40 countries. And now there's huge investment. This is very important. There's huge investment that went into bioinformatics development. So in phase 2, Africa CDC is partnering with CIRI at the University of Cape Town and RPD in Senegal, Pasteur Institute in Senegal, to do 3 major things. One, take all of the sequencing data and try to translate it into action, somewhere to store data and build capacity. And the capacity will be built to answer research questions and to lead to job creation for youth on the continent. So these are all instances where Africa CDC partner with continental organizations across multiple countries. So that has been shown and demonstrated in the midst of these challenges. The piece that is left now is to take those examples and tie them into a continental framework.
How important is ethics and the development of ethical frameworks in improving research and development? Does Africa CDC have frameworks in place to improve ethical conduct?
I think that has been shown in multiple research as one of the reasons why we have very limited research on the continent. We have underfunded, understaffed, inadequately trained ethical research entities on the continent, in the countries. And so the level of confidence in the data by researchers in the global north of pharmaceutical industry has created some reluctance to invest in the continent as one of the major issue, ethics and regulation. But the other end to it is without a strong, qualified, robust, ethical regulatory entity, there's always a high chance for abuse of research, abuse of participants. We're trying to run a multi-country trial in the DRC. So I was up like 2 a.m. speaking to a colleague from Panta and was saying, Mosoka, we have to ensure that when we set up the research centers in the DRC, we'll do what we call the optimum standard of care. In the entire clinic, if we say we have a room in the clinic where only those who participate in the study get better treatment, obviously it's unethical because people who choose not to get into the study don't get the treatment. So the thought is that we have to create strong ethical basis so that the hospital we invest the trial in is up to standard, whether you opt in or opt out of the study. So there's a part of abuse of patients, and there's a part of people don't trust the data if it doesn't have a solid ethical group. One of the things that they have shown that some studies sometimes take 200 to 300 days because there's a weakening ethical system, ethical group that takes such a long time to get the study to be approved. And some of these studies are time sensitive, and so it leads to, again, further has a negative feedback loop because then we don't have studies to get started on time. People are reluctant to get in country because of a weakening ethical. So there's an abuse part, and there is a lack of an enablement for research if the ethical system and regulation is weak. And so in terms of what we tend to do, even before I took what there has been efforts to develop a strong ethical framework for outbreak. So 15 African experts were recruited to develop the framework. What we are now doing is to expand that framework. So for all research on the continent, we'll have two goals. We're trying to create a continental ethical body that will have two major goals, to look at multi-country trial, but also to build the capacity. The most urgent task I've mandated the team is that by December we want to launch an online course on research ethics and regulation. So that I've been meeting with the team every day and pushing them that we have to launch this course by December. So that we want our first online course on ethics so that all Africans can have access to that. That's one way we want to do it. We're also going to develop a second course on clinical trial design because all studies have shown is this inadequacy in ethical capacity that is delaying research on the one hand because it's not enabling, but also have a high propensity to expose our citizens to unethical medical practice and research. Undue influence to research. You do know research should be autonomous, it should be voluntary, it should have equity and justice. But if you don't have a strong framework, there's a high possibility to increase abuse.
Just to get an idea or a glimpse into the future, what would an improved research and development system in Africa look like at a grassroots level and the impact this would have in communities?
Honestly, if you're able to have a solid research, in the case of outbreak, I was involved in the first Ebola vaccine research. Actually, it's a very interesting story. We are about to publish a book. So a friend wrote me and said, Mosoka, the book is almost done. We call it Research in Outbreak Response. We started writing the book 5 years ago when I was at the NIH. Was like, we got to make research as a part of response. The reason I'm saying this to say that when there is an outgoing outbreak, you must be able to do research quickly to get a vaccine candidate and therapeutics to the patients. I'll give you an example. By the time the Ebola struck Liberia, the Ebola vaccine at the time was just in a phase 2 trial. We got it all to Liberia. There was no good research facility. It took us 3 months to build the clinical sites, flower material from the US, flower researcher from the US. By the time we launched the first clinical trial, because the goal was we're going to do what we call a nested trial. We're going to do a phase 2 trial, see if the vaccine was safe and could give response. Then we're going to move to an efficacy trial so that we could quickly vaccinate the population, getting data. But by the time we were able to build it, there was no infrastructure. People were dying, were waiting. By the time we got the infrastructure up, the outbreak had ended. Fast forward 10 years, Ebola in Uganda, Ebola Sudan. The vaccine arrived. By the time it could be ready to get vaccinated, Ebola ended in Uganda. So building strong research capacity before even outbreak happens is so critical, because then you can get medical product quickly to people. Now we have some good rule we call the animal to human rule. If you see that the medical product, the vaccine is effective, can protect life, you can move them quickly to humans. So we've seen some of those. So gradually the changes are happening now. So at the grassroots level, when people are dying, they want to see a change. That's why you see this big vaccine now that is being rolled out for the MVA vaccines. The LC6 vaccine from Japan is being rolled out now in the DRC. But when you have the infrastructure, it's easy to roll the medical product, the therapeutic to the patients in the community, because they want result. You know, the ambassador was saying something to us. There was a time when people were coming to us and asking for anything. They just want to live as their loved ones were dying. People were being wiped out, but there was nothing. She said, but by the time the vaccine got ready, nobody wanted it anymore, because timing was everything. In outbreak response, timing is everything. There are diseases that are unique to the continent. I was reading an article that said now in Africa, more people die from cancer compared to malaria now. Malaria and TB. One point in time, Africa was known for infectious diseases. But the left side, everything now we see the emerging and non-communicable diseases like the cancer, the cardiovascular diseases. But in terms of research, we have very minimal input in research for cardiovascular disease and NCDs. But it's becoming a problem and threat. So for the person at the community level, investing in research so that we can quickly be able to translate that into treatment for them is what they need. Creating a research literacy to understand that clinical trial is good, protecting them through strong ethical framework. These are all critical things that must happen. Like yesterday in Africa CDC through the Science Directorate, we are moving in full speed. So the time is now. It's very urgent that we coordinate as a continental body to coordinate research, create an enabling environment to be able to promote research, create an environment where researchers that are trained in Africa can be able to be retained on the continent. So the work is hard. It's a Herculean task. But the good news is that we're trying to develop advocacy so that the AGIA's declaration that asks for member states to contribute 2% of their budget for R&D, we have to build domestic financing. So we're going to work together. We have our work cut off for us, advocacy, coordination. But I think Africa CDC, under the leadership of Dr. Jean Cassia, is committed to doing this.
In closing, do you have any words of encouragement you would like to share with colleagues, funders, policymakers, and other role players who are contributors in African public health care?
I think we just need to advocate more. Advocacy is critical. Political will is critical. Working towards educating our people. I know we have an audience. Maybe we might think of a scientific audience, but sometimes we make a mistake of trying to develop these messages for the scientific audience and others, but we don't think on our politicians and the policy makers. These are the people that we need to convince, try to reduce messages to their level so they can understand why they should invest 2% of their budget into R&D. No matter how good intention you are, the external people are always, every human being is driven by their self-interest. We need to see a continent where there's intentional and deliberate efforts to invest R&D into research, because that changes our people's life and also help us to coordinate better. Countries that are more advanced can help weak countries in research. But Africa is the last continent now, the last frontier for clinical research, and the time is now.
Thank you to Dr. Mosoka P. Fallah for joining us on this episode. Whether you're an expert in the field of public health or simply interested in learning more, the Africa Public Health Podcast is here to serve as a reliable resource for you. Please get in touch at africacdc.org. Until next time, I'm Andisiwe Michelle May. This is a Volume Podcasts production.